Hi everybody, in class we've explored the origins and signs, symptoms of depression. It's important to remember that treatment with medication and depression should be for patients with moderate or severe episodes of depression, and it should be used in conjunction with psychological therapies, something like cognitive behavioural therapy or interpersonal therapy. I think we know, and having discussions with you in class, that we know that that's not always the case. And medication can often still be used as first line intervention, but important that we as nurses know that so that we can advise our patients and our colleagues on the best course of action. So here we're just going to break down the medications in depression into 3 short videos. I'll give you a little bit of background here and then look at SSRIs in this section, okay? Obviously, when we're given medication, we're looking for some action within the body. In this case, in the case of antidepressants in the brain, an action on neurotransmitters, which I'll address in the next slide. 3 areas of the brain that are important here: the hippocampus, which stores memories of events and responds to stress hormones; the prefrontal cortex, which is aligned to emotional regulation; and the amygdala, which is in charge of basic emotions. In the case of the hippocampus and the prefrontal cortex, it's said to shrink slightly in people who are experiencing depression. In the case of the amygdala, it's said that it can become overactive and that can lead to physical problems or sleep problems. So SSRIs in this case are looking to impact on neurotransmitters in these areas of the brain in depression. So I hope that makes sense to you. In my class, we talked a little bit about the neurotransmitters that are implicated in depression, and there's 3 main neurotransmitters: serotonin, dopamine, and norepinephrine, which are implicated in depression, and 1 enzyme, monoamine oxidase. Together, serotonin, dopamine, and norepinephrine are known as monoamine neurotransmitters. Monoamine oxidase is an enzyme that breaks down these neurotransmitters in the synaptic gap. Okay, so SSRIs work to stop the serotonin, dopamine, or norepinephrine being retook back in to the neuron. So they have an action that prevents these neurotransmitters moving back into the neuron. Yep. Monoamine oxidase medication, or MAOI inhibitors, stop the action of the enzyme in the synaptic gap, thus stopping these monoamine neurotransmitters being broken down. So basically, all antidepressants attempt to increase these monoamine levels within the synaptic gap. And that relates to the theory that depression is in some way related to a reduction in activity of these neurotransmitters within the gap between neurons in those areas of the brain. Yeah? So that's at a very basic level, and you can do a lot more reading on that, but at that basic level, that is the action of these medications, all of the ones that we're going to talk about in this section. Okay, there are a number of different SSRIs used in this class. I guess you've come across most of them, or probably maybe all of them. You can see the action on the neurotransmitters here. Obviously, they all have high action on serotonin, as the name would apply. One of the questions to ask is, despite the levels of neurotransmitters immediately increasing in the synaptic gap, it still takes a number of weeks for these medications to act. And that's a bit of a quandary to those who research in this area about why that's the case. Nobody's really come up with a definitive answer for that. Each of the different SRIs have different effects. Some are more sedating, some are better at reducing anxiety, some are better at reducing distorted thoughts and negative thinking, etc. So each patient should be judged in relation to their symptom profile depending on what medication they're going to be started on. On the next slide, we're going to talk about side effects, because one of the biggest issues in relation to concordance with medication, or with patients stopping medication, ultimately is the impact of side effects. SSRIs are said to have fairly few side effects, but the ones that they do have and that continue for some time are quite distressing for patients. So you can see some of the common reported side effects that are probably most distressing for patients are things like weight gain or loss, a general apathy or emotional blunting, sleep disturbance, and in particular vivid dreams and nightmares, and problems with sexual dysfunction. Now, many of the side effects are said to be more prominent in the first 4 weeks of prescription. However, sexual dysfunction in particular, and in particular difficulties in achieving orgasm, can last for the course of treatment and beyond. And it's important that we as nurses are cognizant with the side effects that patients may have when taking SSRIs and are able to honestly discuss side effects with patients. Another question that many patients might ask you is, are SSRIs addictive? When patients are asking you that question, they're probably worried about discontinuing medication and when stopping if there are any withdrawal symptoms. In SSRIs, there are withdrawal symptoms, but they tend to be called discontinuation issues rather than withdrawal symptoms. Initially, these can look like flu symptoms. Patients can have irritability, agitation, poor concentration. I think really importantly for us as mental health nurses in the front line working with patients, really sometimes increases in suicidal thoughts as the medication is reduced. That could be a time of risk for the patients, could be a time of distress for the patients. What's important is that a stepped approach to reduction is taken. Patients who immediately stop their medication are probably more at risk of discontinuation symptoms. So it's important that we have that discussion about a measured approach to stopping or changing medication. So one of the things that's important to know about is something called Serotonin Syndrome. So while generally safer than many other antidepressants, there is a risk of Serotonin Syndrome in a very small number of patients, or for patients who have overdosed in SSRIs. This can be a potentially life-threatening reaction to SSRIs, adverse reaction to SSRIs, and it can lead to mild, moderate or severe changes to mental state here, motor functioning, cardiovascular issues, gastrointestinal issues, and other issues, things like fixed pupils, excessive sweating, hyperthermia, and rapid breathing. In most cases, in mild or moderate cases, then stopping the medication will be enough to abate the serotonin syndrome symptoms. In severe cases, this can be potentially life-threatening and it is a medical emergency, so prompt attention needs to be delivered in those cases. As we say, it's very rare. They say something like 0.4% in 1,000 monthly cases. It's minuscule. However, as nurses, we need to be aware that any changes in these 4 main areas or observation of the other symptoms when somebody's just started on an SSRI might indicate serotonin syndrome. So just be aware of that. Perhaps read a little more into it as well. Finally, I just want to talk about SSRIs in young people. So people kind of, I don't know, I would say up to 18 especially, but sometimes beyond that, there is good evidence that SSRIs do increase suicidality in young people. So there's only one SSRI licensed for use with adolescents, and that's fluoxetine. Young people on SSRI should be monitored closely for their thoughts around suicide and self-harm, and we should be aware that there may be an increased risk of those thoughts of self-harm or suicide in young people who are prescribed SSRIs.